when we come to arterial blood gas analysis, the three important aspects which an arterial blood gas tells you is the oxygenation, the ventilation, and the acid-base status. So I'll take you through one by one through each of these. So when we talk about oxygenation, the pointers which tell us about the oxygenation of the patient are PO2, the PaO2 by FiO2 ratio, the alveolar arterial oxygen gradient, the saturation on the arterial blood gas, and you can calculate the arterial oxygen content. So what do you understand by PaO2? PaO2 is nothing but the arterial oxygen tension, that is the dissolved oxygen in the circulation. And hypoxemia is defined as PaO2 of less than 80 millimeters of mercury at sea level in an adult patient. Each of these words are important because I will come to that in a minute. So at PO2 of less than 80 at sea level in an adult patient who's breathing room air. So tissue hypoxia is unlikely in mild hypoxemia when the PaO2 is between 60 and 79, but it is always associated with severe hypoxemia. That is when the PaO2, tissue hypoxia is always there when the PaO2 is less than 45 millimeters of mercury, giving rise to anaerobic metabolism, lactic acidosis, etc., and so on. So whenever we look at the PaO2, it should always be interpreted in relation to concentration of the inspired oxygen, that is the FiO2, and the age of the patient. The way in which the age affects the PaO2 is that the PaO2 is calculated as 100 minus 1/3 the age. This is a rough formula. So the accurate formula is 104 minus 0.27 into age. So in a 60-year-old patient who's breathing room air, so 1/3 of 60 is 20 and 100 minus 20 is 80. So you expect a PaO2 of 80. So age is the first factor. The second is the FiO2 that the patient is breathing. So normal PaO2 in an adult breathing room air, that is 21% oxygen, 0.2 FiO2 is 80 to 100 millimeters of mercury, which is roughly 400 times. Okay, so the normal PaO2 by FiO2 ratio is 400 to 500 millimeters of mercury, or 4 to 5. So when the PF ratio is less than 200, it indicates a shunt greater than 20% and is most common in ARDS and acute lung injury, right? So in a patient who's breathing 100% oxygen, that is 100% FiO2, you expect the PaO2 to be between around 400 to 500 on arterial blood gas. So we finished PaO2, we came to PaO2 being affected by age, then the PF ratio, then the next aspect, that is the alveolo-arterial gradient. So it predicts the degree of shunt comparing the partial pressure of oxygen in the alveoli to that in the artery. The difference between them gives us an idea of how well the oxygen is moving from the alveoli to the arterial blood. So the PaO2 is obtained from the arterial blood gas, and the capital AO2, that is the alveolar partial pressure of oxygen, is obtained from the alveolar gas equation. So this is the alveolar gas equation for you. Okay, that 760, which is the atmospheric pressure. This is the pressure of water vapor multiplied by FiO2 minus PaCO2 divided by respiratory quotient. So in a person, which is 1. So in a person who breathes room air, it is 150 because the FiO2 will be 0.2. So 150 minus 1.25 into PaCO2. The normal alveolo-arterial gradient is 10 to 20 millimeters of mercury. And when the patient is not breathing room air, it is calculated as 760 minus 47 multiplied by the FiO2. So if the patient is breathing 100% FiO2, you will get this as 100 or 1, right? Minus 1.25 into PaCO2 minus the PaO2 obtained from an arterial blood gas. Now, what are the conditions in which you will get an elevated alveolo-arterial gradient? When you have dead space ventilation, that is zone 1 in the lung, where there is overdistension of the alveoli, and as a result of which there is dead space ventilation like pulmonary embolism. There is no gas exchange taking place. Then you have right to left shunt, that is pulmonary edema, ARDS, pneumonia. And when there is a diffusion problem like pulmonary fibrosis and interstitial lung disease. Coming to the next, what is the alveolar, what is the oxygen content? The CaO2. The CaO2 is given, as you all know, by an equation that is 1.34 into hemoglobin multiplied by the saturation plus 0.003 into the PaO2. And this content multiplied by the cardiac output gives you the oxygen delivery. So this was all about the oxygenation that you can decipher from the arterial blood gas. The PaO2 affected by the age and the FiO2, the PF ratio, the alveolo-arterial gradient, and the oxygen content. Moving on to the next, that is the EtCO2 and the PCO2. Under normal circumstances, the PaCO2 is always more than the EtCO2. Okay, because the EtCO2 is diluted by the dead space gases, as a result of which the partial pressure of carbon dioxide in the expired air or end tidal carbon dioxide is a little lower than the partial pressure of carbon dioxide in the blood. The normal difference between these two is roughly 2 to 5 millimeters of mercury. In a diseased lung, there is a wider gap, okay, or in a sick lung where there is a lot of dead space ventilation, which I will come to in my next slide, the EtCO2 PO2 gradient is much higher. So let's come to this example. If you have heard of the west zones of the lung, this is zone 2, where the alveolar ventilation is also taking place and the perfusion also taking place. So the normal gradient where the gas exchange is taking place, the EtCO2 drops to is around 38 and the PaCO2 is around 40. So the gradient is between 2 to 5, EtCO2 and the PaCO2. When you have dead space ventilation, there is an over-distended alveoli in the zone 1, where the alveolar pressure is much more than the arterial and the pulmonary venous pressure. There is no flow and no gas exchange taking place, as a result of which there is the CO2, partial pressure of CO2 in this alveolus is 0. And when this balances on from the ventilated and perfused alveoli, the EtCO2 is low. So when there is dead space ventilation occurring, the EtCO2 is low and the PCO2 value remains the same. So as a result of which the PaCO2 and EtCO2 gap is much higher in this dead space ventilation. Whereas in a shunt flow, where there is flow happening but no ventilation, the EtCO2 and the PCO2 gap is maintained. Okay, this is the zone 3 that you talk about, the zone 2, the zone 1, and the zone 3. Okay, where you have dead space ventilation, shunt flow, and normal ventilation perfusion. Okay, so that is for the ventilation bit. Coming to the CO2 values, the respiratory acidosis and alkalosis, which is also an indicator of the ventilation and alveolar ventilation. I will discuss that along with the arterial blood gas analysis. So these are the normal ranges on which the assessment or assumptions are made that the arterial blood gas analysis takes place. The pH, TCO2, PO2, bicarb, oxygen saturation, and the base excess. These are the normal values taken as reference ranges. Now, moving on to the third thing, after oxygenation, ventilation, steps for acid-base analysis. Okay, so if you go in a systematic format for analysis of an acid-base balance, you will never miss out on anything. Now, since my topic of arterial blood gas analysis is perioperative point of care arterial blood gas analysis, I will not be covering the mixed disorders in very much detail because you seldom get these kind of patients. More often than not, the patients who come up for surgery are pure or compensated metabolic or respiratory derangements and not the mixed disorders, right? So that is a talk in itself. So I will not be covering that. So let me go through the steps for you for acid-base analysis. You have the first step, that is whether the patient is has acidemia or alkalemia. The step 2, that is what is the primary disturbance responsible for the acidemia or alkalemia, whether it is respiratory or whether it is metabolic. If the pathology is respiratory, you follow steps 3 and 4, whether it is acute, chronic. The step 4 is whether there is any metabolic compensation associated with the acute or chronic respiratory pathology. If the patient has metabolic pathology, follow steps 5, 6, and 7 if there is a mixed disorder. So 5 is how much is the respiratory compensation. Step 6 is calculate the anion gap, which is high anion gap or normal anion gap. And all these steps have to be performed after correlating it with a history and examination and coming to a correct diagnosis. So moving on to step 1, you have the pH between 7.35 and 7.45, which is the normal range. Anything below 7.35, as you all know, is acidosis, and above 7.45 is alkalosis. Okay, so to give you a case scenario, a 24-year-old patient presented to the casualty with an oxygen saturation of 88%, And the arterial blood gas was pH of 7.25, PCO2 of 60, PO2 of 65, bicarbs of 26, base excess of 1. On the chemistry panel, her sodium was 137, chloride 100, and bicarb 27. How will you proceed with the evaluation? So coming to step 1, is this acidemia or alkalemia? As you can see that the pH is 7.25, so it is suggestive of acidemia. Okay, so step 1, it is acidemia or acidosis. So you move on to step 2, whether it is respiratory or metabolic. An important thing to check here is what is the direction of the movement and what is the primary pathology. So if your pH is acidotic and your carbon dioxide has moved in the opposite direction, okay, it is respiratory pathology. And if your bicarbonate moves in the same direction as the pH, it is a metabolic derangement. So this is given by the Henderson-Hasselbalch equation, that the pH is directly proportional to the bicarbonate and inversely proportional to the partial pressure of carbon dioxide. So in primary respiratory disorders, the pH and PCO2 change in opposite directions, and metabolic disorders, the pH and bicarb change in the same direction. So to summarize, you have the pH. When the pH is in the acidotic range, you check what the bicarb is. If it is the bicarb is less than 22, it is a metabolic acidosis. If the PCO2 is more than 42, it is a respiratory acidosis. So what is the predominant primary pathology? If the pH is more than 7.42, it is alkalemia. And if the bicarb is elevated with the pH rise, it is a metabolic alkalosis. And if the PaCO2 is less than 38, it is a respiratory alkalosis. So to summarize, to give you a case scenario, this was the first case that we had discussed, that the pH is 7.25, PCO2 of 60, PO2 of 65, bicarb 26, and base excess 1. We said it is acidemia. Now, what is the primary pathology? Since the bicarb is near normal, the PCO2 is elevated, it is a respiratory derangement. It is respiratory acidosis. Okay. So step 2, we've moved to whether it is respiratory or metabolic. This scenario is of a respiratory acidosis. Now, before I move on to step 3, 4, and so on, we'll discuss something what is a compensation. What do you mean by compensation? That the body always tries to normalize the pH back to normal, but the compensation never returns the pH to back normal or never overcorrects the pH. Okay. So the carbon dioxide and bicarbonate should rise and fall together in simple disorders. So whenever you have a respiratory pathology, the bicarb tries to compensate by moving high or low and getting the pH to normal. Compensatory responses require normally functioning kidneys and lungs. Acute compensation occurs in case of kidneys occurs within 6 to 24 hours and chronic within 1 to 4 days. And respiratory compensation occurs faster than the metabolic compensation. So these are some of the rules of compensation. Now moving on to the respiratory pathology, the step 3, that once you have the acidosis and the respiratory acidosis, you have to find out whether the pathology is acute or chronic. So how do you find that out? There's a formula that the change in the pH, if it is in acute pathology, is given by the delta PCO2 multiplied by 0.008. And in a chronic respiratory disorder, the PCO2 multiplied by 0.003 gives you the change in the pH. So to give you an example, okay, this is the same case that I'm continuing, that you can find out the delta PCO2 is 60 and the baseline is a 40. Okay, so 20 millimeters of mercury is the delta PCO2. When you have to multiply this 20 by 0.008 and 0.003 and check which pH, what is the value of pH in the clinical condition closer to. So in this case, when you multiply it by 20 multiplied by 0.008, it gives you a figure of 0.16. So 7.4 minus 0.16 gives you 7.24, which is close to the clinical pH that you have got on the acid-base gas status, right? So that means that this is an acute respiratory acidosis. Okay. So this is the step 3. You have to find out whether it is acute or chronic. Following this, you find out how much is whether there is any metabolic compensation. Now, this is arterial blood gas, as you all know, is a little challenging in terms of remembering formulae. So all you have to do is you have to get these formulae imbibed in your head, And only when you do that can you actually get a correct decipher the ABG correctly. So usually compensation does not return the pH to normal. If the observed compensation is not the expected compensation, it is likely that you have a mixed disorder. Okay, but that we are not going to be covering. So when you have acute respiratory acidosis, okay, the expected bicarbonate for compensation is the baseline bicarbonate, that is 24 plus 0.1 into delta PCO2. This is usually, there is a 1, 4, 2, 5 rule. So 1 and 4 for acute and chronic respiratory acidosis, and 2 and 5 for acute and chronic respiratory alkalosis. So if you read the books and the formula, it is said that for every 10 millimeters of mercury change in pH, okay, the bicarb changes by 1 in acute and by 4 in chronic respiratory acidosis. So we've done exactly that instead of that 10 change, we've made it 0.1 and 0.4. So 1 on 10 and 4 on 10, and the change in the PCO2. Okay, I'll come to that when I discuss the case scenario, and it'll become a little clearer, right? So this is for acute and chronic respiratory acidosis. We move on to acute and chronic respiratory alkalosis, that the expected bicarb is less. So baseline bicarbonate minus, there it was plus because the compensation in acidosis will be elevation of the bicarb, whereas here in alkalosis, respiratory alkalosis, the bicarb will try and come down to get the pH lower. Okay, so baseline bicarbonate minus 0.2 into the delta PCO2 and 0.5 into delta PCO2 for a chronic respiratory alkalosis. So again, coming to another case scenario, that this is 7.37, PCO2 of 57, PO2 of 70, and bicarb 32. So how do you analyze this? Step 1, what is it? It is 7.37 pH. That means there is acidemia. Okay, so you move on to the next step, whether it is respiratory or metabolic. Okay, here we have the PCO2 which is elevated, which is in the direction opposite to that of the pH change, suggesting it is respiratory acidosis. Okay, move on to the step 3, whether it is acute or chronic. So delta PCO2, that is 57 minus 40 PCO2, which is the baseline PCO2. So that gives you 57 minus 40, which is 17. Okay, and you multiply it by 0.008 and 0.003. So in this case, when you multiply 17 by 0.003, it gives you 0.05. And when you deduct 0.05 from 7.4, it gives you a pH of 7.35, which is close to this pH, suggesting that it is a chronic respiratory acidosis. Now you have to find out whether there is any compensation here, metabolic compensation. So let's check that. Okay, so compensation, the expected bicarbonate should be baseline bicarbonate, which should be 24. And in what was the formula for chronic respiratory acidosis compensation? It was 0.4 multiplied by delta PCO2. So 24 plus 0.4 into 57 minus 40, which is 17. Okay, so gives you 7. So 27 plus 24 plus 7, which is 31, which is close to the bicarbonate that you have here. So your diagnosis would be, it is chronic respiratory acidosis with compensated metabolic alkalosis. Okay, because the bicarb has risen here. So you move to step 3 and 4 when it is respiratory pathology, and step 5 and 6 I'll come to a little later. So what are the common causes of acute respiratory acidosis? Whenever there is an airway pathology, upper or lower airway pathology, pulmonary problem, ARDS, pulmonary perfusion defect, ventilatory restriction, central nervous system disorders, or over medication with narcotics, neuromuscular deficit because of spinal cord injury or blocking drugs. Causes of respiratory alkalosis are hyperventilation, any hyperventilation which washes out the CO2, like fever, thyrotoxicosis, pain, certain drugs like progesterone, salicylates, pregnancy, anxiety, fear, psychological responses. These are some of the causes of respiratory alkalosis. Now, we discussed the respiratory pathology, coming to the metabolic pathology. So if you have on step 1 and 2, you have acidosis and you have metabolic acidosis, you move to step 5 and check whether there is any respiratory compensation. So for metabolic acidosis, the respiratory compensation is given by Winter's formula, which is you expect a PCO2 of 1.5 into bicarb plus 8 plus or minus 2. Here the hint is the expected PCO2 should be same as the last two digits of your pH. Okay, that makes it a lot simpler instead of remembering formulae. Okay, similarly for metabolic alkalosis, the expected PCO2 is 0.7 into bicarb plus 21 plus or minus 1.5. I'm sorry, there's a lot of formulae, but I guess if you want to crack your ABG, you have to know these formulae by heart, right? So there is no other solution to this. And if the actual PCO2 is more than the expected PCO2, there is a hidden respiratory acidosis. Okay. And if the actual PCO2 is less than the expected, there is hidden respiratory alkalosis. Now, this is a bit confusing, but when I give you a case scenario, I'll make it a little more clear, right? After finding out whether the respiratory compensation is adequate or not, you move to step 6 and calculate the anion gap. Anion gap is nothing but you add the electrolytes, sodium, chloride, and bicarbonate. The normal anion gap is around 12. If the anion gap is higher than 12, it is termed as high anion gap. And if it is less than 12, it is termed as normal anion gap metabolic acidosis. Now, whenever there is hypoalbuminemia, okay, you have a correction for the albumin, which is the observed anion gap plus 2.5 multiplied by the normal albumin, which is taken as 4 minus the observed albumin. Okay. Okay. So what are the causes of high anion gap metabolic acidosis? There's a mnemonic for this. Perioperatively, we have this common mnemonic, the CULT, okay, which is the ketoacidosis, which is diabetic, starvation, alcoholic causes for ketoacidosis, uremia, lactic acidosis, and toxins. There is another mnemonic which is also described, that is mud piles, which includes methanol, paraldehyde, INH, ethylene glycol or antifreeze, and salicylates. These are more commoner in the ICU setup. Okay. The causes of normal anion gap metabolic acidosis are ureteral diversion, diarrhea, ileostomy, renal tubular acidosis when they are hypokalemic. When they are hyperkalemic, it is distal renal tubular acidosis, tubular necrosis, hypoaldosteronism, and dilutional acidosis, hyperalimentation, etc. So perioperative causes of metabolic alkalosis are when there is laxative abuse, diuretic use, contraction alkalosis, renin secreting tumors, mineralocorticoid excess, Cushingoid syndrome, and whenever there is a loss of hydrogen ions like vomiting and nasogastric tube suctioning. So let's move on to the case scenario. Okay, so we understand better with this. You have a 45-year-old male is admitted to the ICU with pancreatitis, where the pH is 7.33, PCO2 of 30, bicarbs of 15, lactates of 6, albumin of 2, sodium of 136, potassium 4.5, and chloride of 108. The first step, we move stepwise. The first step here, the pH. So the pH is 7.33, which is in the acidotic range. It is suggestive of acidosis. Okay. Here, the next thing, whether it is respiratory or metabolic. So the PCO2 is in the same direction as the pH. Okay, which should be in the opposite direction if there's a respiratory pathology. But the bicarb is in the same direction. So it is a metabolic acidosis. Right. So bicarb is 15. So metabolic acidosis. So when you are in the metabolic pathway, you move to step 5 and 6. So let's move to step 5. Is there an associated respiratory compensation? So what is the formula for respiratory compensation with metabolic acidosis? Winter's formula, or the PCO2 should be the same as the last two digits of the pH. So here you can see that the PCO2 is very close to the pH digits 30 and 33, which is suggestive that there is respiratory compensation by the patient is trying to hyperventilate and wash out the CO2 to get the pH back to normal, right? So that is compensated, metabolic acidosis with respiratory compensation. Then you move on to the anion gap, whether it is high anion gap or normal anion gap. So high anion gap or no, so you add the sodium, okay, and chloride and bicarbonate, and you find out that the anion gap is elevated, okay, 13, which is more than 12. But here again, the albumin correction, when you add that, so 4 minus 2 is 2 multiplied by 2.5, which is 5, and you add that to 13, okay. So that gives you 13 plus 5 and makes it 18. So this is high anion gap metabolic acidosis. So your complete diagnosis will be high anion gap metabolic acidosis with respiratory compensation, and the cause for high anion gap metabolic acidosis is elevated lactates. So CULT, here you have ketoacidosis, uremia, lactic acidosis, and toxins. So here the lactates are elevated due to inadequate tissue perfusion and shock with the patient in pancreatitis, which is giving rise to the high anion gap metabolic acidosis. So thank you very much. And with that, I end my talk. You can type the questions in the chat box, and they will come to us, and we can answer that. And I will be happy to take questions at the end. And I'll invite the next speaker of this point of care testing webinar, which is Dr. Shilpushp Bhosale, and he is the professor in the Department of Critical Care Medicine, and he's a very dynamic intensivist, and he's going to talk about point of care ultrasound for you. Thank you.
Thank you, Dr. Jeson. I would also like to thank the ClearNet as well as the Indian College of Anaesthesiology for giving me the opportunity to speak to this August gathering or the seminar or the webinar. So point of care ultrasound is actually a very emerging tool, in clinical practice, which not only helps in in diagnosis but also in treatment. So when you say it is more the things that you have to understand about point of care ultrasound, it is that it is non-anatomical. Uh, when I say that this is moving lung, it is more of a leap of faith. You have to understand those patterns, and believe me, after you get hands-on practice on it, it will become easier, and you'll be proficient in use of ultrasound. I will only give you a brief overview of what are the applications of ultrasound in routine clinical practice. It all started with regional anesthesia and chronic pain blocks, but with the the latest last decade or so, there is burgeoning evidence of use of ultrasound in other aspects of anesthesiology, like assessment of airway and uh, stomach, or for gastric ultrasound, look at vascular access, which is also been used for a long time. Then there has been increasing use in transthoracic and transesophageal echocardiography, though transesophageal echocardiography was used in cardiac anesthesia for a long time, but now it is also being used in non-cardiac anesthesia settings. And of course, the lung ultrasound has really picked up over the last decade or so, and there is strong evidence for its clinical utility. And of course, there are certain other uses of ultrasound, that is neuromonitoring, whether you use the ICP pressure measurements with the optic nerve sheath, or
Sorry to interrupt, sir. Your PPT is not visible till now.
oh, 1 second, let me.
Sir, you can stop the sharing and try to again share the screen.
Is it visible now?
No, sir, you haven't shared the screen, sir. You come to Zoom application and share your screen. Yes, fine. Keep it on the full screen. That's like fine, sir. You can
Better?
continue.
Yeah.
Yeah, you can continue.
It's
Thank you so
opening.
much.
Yeah, it's just opening.
Yes. So, like I was saying, its routine applications have increased over the recent few years, and not only in routine anesthesia, as well as cardiography related examinations. It is also used for monitoring purposes. So when you look at basics of ultrasound, human ultrasound is capacity anywhere between 20 to 20,000 hertz. When you say ultrasound, it is like 2 to 15 megahertz. So it's a very high frequency, which is not audible for normal hearing. So, and how is ultrasound produced? So here you have a piezoelectric crystal. Piezo means something that changes shape. So when a current is applied, the piezoelectric crystal changes its shape and it emits sound, and the sound is propagated as a wavelength. So you can see the beginning to end of one wave is called one cycle, and the amplitude of the sound determines the wavelength, and these amplitudes would determine what is the frequency of the ultrasound wave, and depending on these frequency, you are able to assess whether the ultrasound can see the amount of depth that it can visualize in the body. You have to always remember that higher frequency probes are good for superficial structures because they are good in resolution, but they lack penetration because the wavelength is not very high. And for lower frequency probes, because the cycle length is high and the amplitude is low, they are good for deeper structures. So you can see the cardiac probes, they are low frequency probes, but they penetrate deeper into the tissues and give you good images from a deeper structures. But the problem is they are not good in resolution. So that is the bargain, or that is the trade-off that you get. If you have good penetration with low frequency probes, you have poor resolution. But superficial probes, like higher frequency probes, are good for superficial structures and they have got a good resolution. Okay, so this is the point that you have to remember when you select your probe for examination. So superficial structures, high frequency probe; deeper structures, low frequency probe. That's what you need to remember. So like you see here, the higher frequency probe is 6 to 15 megahertz. They are good for superficial structures. So we use these probes for ultrasound guided nerve blocks, or using line cannulations. And these are the lower frequency probes, like 2 to 5 megahertz or 1 to 5 megahertz. These are used for deeper structures. So low frequency, good for deeper structures. And this is the phased array probe. It emits ultrasound in a phased manner, so that it will give you a conical image, so that from a smaller structure it will give you from a smaller window it will see larger image. So you can see between the rib shadow, because there is a space is low, it will look at the wider area of the heart. So that's why you use the phased array probe for cardiac ultrasounds. Then the next thing that you have to know is mode of scanning. So mode of scanning, there is B mode, or the brightness mode. We normally call it as the 2D mode. So it is only giving you image in a grayscale. Then you have the M mode. M mode is the motion mode. So when you put a sample gate on a particular point or a particular line, at that point, whatever the image is depicted as a motion, as a movement mode. So that is what you need to know when you look at movement of the lung or movement of the cardiac valves. Those are used, those structures assessment is done on an M mode. And the last mode is the Doppler mode. So spectral Doppler, again, it is of three types. One is the pulse wave Doppler, where you can actually put a sample volume at a particular point and look at the speed of the flow at a particular point. The other one is the continuous mode Doppler, which looks at the flow from a particular line. So it will not be able to pick up a flow from a particular point, but it will look at the flow on that line that you put it. And of course, the last one that also we used routinely is the color Doppler. So it will give you the flow in terms of color. So we say when the blood is moving away from the probe, it is shown as blue. When the blood is moving towards the probe, it is shown on the screen as red. So that is the other way of looking at the flows. So Doppler mode is for flow or movement. M mode is for movement over a particular line, and B mode again is the brightness mode. So when you look at the how do you scan? So there is for whether you do a ultrasound guided nerve blocks, or whether you do the central line placements or arterial line placements, you use these in plane or out of plane approach. So if the needle is within the plane of the probe for most of the time, you call it as the in plane approach. If the needle is out of the plane for most of the time, you call it as the out of plane approach. So in plane approach, you can see the whole needle length traversing, and it is easier to to actually know where the tip of the needle is. For the out of plane approach, you can see the needle just as a point, because only this part of the needle is visible under the probe. So you may overshoot the needle tip. You need to be aware of this aspect, that when you are out of plane, you should be able to always try and look at the tip of the needle. Okay, so I will briefly touch base on the various applications of ultrasound in routine clinical practice. And like I said, the evidence is emerging, so there may be some aspects which are not very strong in terms of evidence. And as the evidence comes out, we will know that whether those signs or features are consistent in diagnosing or treatment. So for airway ultrasound, it has been used for airway assessment for difficult intubations. Again, not very strongly, but there is a trend towards trying to find difficult airway assessment with ultrasound. Then you have the confirmation of endotracheal tube placement, or for that matter, even for LMA placement. You have good evidence to say the depth of endotracheal tube placements. You have assessment of airway size, where for selection of tube, and this is particularly important in children when where the airway, the endotracheal tube size becomes critical. Then you have ultrasound guided needle cricothyrotomy as a rescue method. So like if you have seen the NAPFOR audit, where it was evident that anesthetists are not very good in locating the cricothyroid membrane. So you can use ultrasound for that. So is for percutaneous tracheostomies. The other one is for prediction of post-extubation stridor, or to assessment of size of double lumen tubes. And of course, if there are any airway pathologies like a huge goiter, a deviated trachea, you can also use ultrasound to assess that. So for airway ultrasound, the commonly used probes are, like I said, the linear probe, which is a high frequency probe, and the curvilinear probe, which is a low frequency probe. So there are ways to scan the airway. Use the longitudinal or the vertical plane, or you can do it in transverse plane. You can use in the sagittal section, or you can use at the parasagittal section. But like I said, the airway ultrasound is still emerging. So you can do the submental assessment of the airway with the help of a curvilinear probe, where you can see the volumetric assessment of the tongue, the relationship of the tongue with the palate, and of course, if there are any base tongue pathologies, you'll be able to diagnose the extent of those lesions. You can use linear probes for anterior neck, simply because it is very difficult to put a linear probe in the submental fossa. So you use linear probe for by and large most of the applications of the airway. So the first thing that you need to identify in the airway ultrasound is to identify the cricoid cartilage, and this is a very taut cartilage which is very well circumscribed and a horseshoe-shaped structure, which is easily visible on the ultrasound. So once you identify the cricoid cartilage, you have a air mucosal line, or the mucosal surface, which is a very hyper reflective surface, and below the air mucosal surface, because there is air in the trachea, you see something called as the snowstorm. And like I said, because the air is the enemy of ultrasound, once the ultrasound passes through the air, it will scatter, and that's the reason why you get something called as the snowstorm appearance in the normal airway. If you put the ultrasound transversely, you can see you can identify the trachea, you can identify the thyroid, but critically you will be able to identify what is called as the esophagus on the left. And if you have identified the esophagus, if you unfortunately have a endobronchial the esophageal intubation, you will be able to pick up a real time. You can pull it out and put it again into the trachea. So that is one good application of identifying the esophagus in ultrasound, with the ultrasound during actual intubation procedure. The other thing is, when you put the probe in the vertical or longitudinal plane, This tout cartilage, as I said, is the cricoid cartilage. You can identify the first tracheal ring as a long, slender cartilage, and of course, you can have identify these other cartilages like the string of pearls or beads of pearls, what is classically described in airway ultrasound. Once you identify this, similarly, like we saw in the earlier image, this white shiny structure is the air mucosa line. So the interface where the air and mucosa interact causes this hyperreflective surface, which is the air mucosal surface, and the artifacts that are produced at this air mucosal surface are generally described in terms of the signs of ultrasound. So here you can see when you scan the ultrasound, you can identify the thyroid, you identify the cricoid, and of course you can go down and identify the tracheal rings. And this is what is described as the snowstorm appearance in normal ultrasound. When you move the probe from longitudinal to vertical plane, you can see that you are able to identify the thyroid. This is the first tracheal ring, and this is the string of pearls or beads of pearls that is classically described in are the tracheal rings. Okay, you can use this form of examination to identify tracheal rings, to identify even the cricothyroid membrane, which I'll come to that little later. So once you go up to onto the thyroid cartilage, you can actually see the movement of vocal cords as well. So if you are suspecting a vocal cord palsy after a thyroid surgery, you may actually look at movement of vocal cords in real time and decide whether you want to delay your extubation post thyroid surgeries, or if there is a diagnosis to be made of a vocal cord palsy. So you can identify the arytenoid, you can identify the false cords, but these shiny white structures are identified as the true vocal cords. Regarding assessment of difficulty of airway, like I said, there are various studies that have been looked at the tongue base to the skin length, the diameter of the width of the epiglottis and thickness of the epiglottis, the pre-epiglottic space, the skin to hyoid bone, epiglottis thickness, like I said, and vocal cord movements. All these are being evaluated, but there is no strong signal about those predictors for difficult intubation or difficult ventilation. There are certain things that if you are not able to visualize the hyoid bone with the sublingual ultrasound, it would predict difficult intubation. If the hyomental distance does not change with neutral position to extension, you are probably looking at a difficult intubation. Or at the trachea, when if you keep the probe and if the length of the pretracheal distance or tissue is more than 2.8 centimeters, then you are probably looking at a difficult laryngoscopy. So there is some evidence to suggest that the increase in the pretracheal tissue is a predictor of difficult laryngoscopy. But like I said, most important is to identify the cricothyroid membrane. And if you practice long enough, you will encounter difficult can't ventilate or complete ventilation failure scenarios where you might have to get access through the front of necks. So you will have to get into the cricothyroid membrane, whether you do it with your needle or your scalpel bougie, whatever technique you need. For that, you need to identify the cricothyroid membrane. And you can see this clearly with the ultrasound. This is the thyroid cartilage, this one is the cricoid, and this is the cricothyroid membrane. Never assume the air mucosal line to be the cricothyroid membrane, but probably it would not make a huge difference once you are getting access. But point to note is the air mucosal reflection is different from the actual cricothyroid membrane. The other applications, like I said, are to size the endotracheal tube, whether it is endotracheal or a double lumen tube. You can do it at the level of the cricoid. You freeze your image and you look at the length of the tracheal area. So the endotracheal lining, you mark it and you assume the endotracheal lining, and you can look at the outer diameter of the endotracheal tube to select which tube you would want to put. And as I said, this is even more critical when you are dealing with small children. It has been validated for use of endotracheal tube conformation, and like I said, when you have the tube coming into the trachea, there is loss of this snowstorm, and this loss of snowstorm is confirmatory for endotracheal intubation. And if there is nothing, if there is no bulging of the esophageal opening, that means you are in the trachea, and this can be used real time. You do not have to give 4 or 5 breaths for confirming on EtCO2. It can be done actually during the time of intubation. And of course, other scenarios, like if you have a cardiac arrest scenario where the EtCO2 may not be very reliable, you can use these ultrasound methods. Though EtCO2 still is the gold standard for confirmation. So here you can see the bulge or the loss of snowstorm sign when the endotracheal tube gets into the trachea. There are various other signs which have been described, that the triangular shape becomes bulge because, or bullet shaped with the entry of the tube. But loss of snowstorm is pretty much diagnostic for endotracheal intubations. Well, if you look at this image, here is the trachea, and you can see, if when you have an esophageal intubation, you would get a bulge at the esophageal opening, and this bulge is classically described as the double tract sign. So if you see 2 bulges like this, that means you have got a esophageal intubation, because there is no other place where the tube can go but the esophagus, when you have 2 openings which look like trachea. So this is called as the double track sign, which is confirmatory for esophageal intubation. Okay, there is other way of confirming the tube position, and we studied this by using a saline technique, where you can put saline into the cuff and you can measure the length of the cuff at by the ultrasound at the tracheal rings. And if the cuff remains at 3rd, 4th tracheal ring, you are pretty much reasonable in terms of tube position. You do not have to wait even for the X-rays, and especially in OT scenarios, it will be very difficult to get X-rays. So this is one way of confirming the tube position, that you are not too deep or not too high, or you are not endobronchial. You can also use the same saline technique to confirm the placement of the LMA. And if you have, suppose, arytenoid elevation, which would suggest a LMA malrotation, and you can confirm that with saline in the LMA as well. You can use the same vertical probe position to locate the tracheal rings, and you can use the tracheal ring positions for doing tracheostomies, but this is more of ICU related application. Similarly, you can look at vocal cord movements, like I explained before. The last application in terms of the airway ultrasound is to look at post-extubation stridor, and it has been suggested that the mean air column width, if it is more than 1.6, that means there is reasonable space around the tube, and the incidence of post-extubation stridor is less. So you can use this for identifying the post-extubation stridor. The next use is the gastric ultrasound, and we are always worried about delayed gastric emptying, NPO status, patients who are taken in emergency. And if you look at the antrum is the most dependent part of the stomach, and if the antrum is full, there is reasonable chance to say that the patient is not NPO, and the risk of aspiration is high. Of course, we cannot really ascertain the pH, but the gastric volume is one of the things that can be looked at here with the ultrasound. How do we look at? So we have looked at it where you can see, if you put the probe in the xiphisternum, vertically it can be done in 2 positions. One is in supine and one is in lateral position. You put the probe on the xiphisternum in the vertical plane, and you can see the liver surface, and just underneath the liver surface you can see the antrum. So this and this is the portal vein and the splenic vein and the aorta. You can also sometimes see the mesenteric artery or the SMA which comes out from the aorta. So essentially you have to identify the antrum just below the inferior surface of the stomach of the liver. So when you look at the antrum, you can either see a small collapsed antrum, which suggests that the stomach is empty and the risk of aspiration is low. You can see if the antrum is large and with mixed echoic shadows, you can suspect that the antrum is full and the risk of aspiration is high. If there is something called as the frosty glass appearance, this is because of the air mixed with fluid with the size, of course, would tell you that the antrum is, the stomach is full and the aspiration is high. And if the stomach is clear and the antrum is full, but it is clear, this you can see when you have API immediately and you take the patient for surgery, you will be able to see a clear antrum in the gastric ultrasound. You can also have volumetric assessment. If the cross-sectional area is less than 4, the stomach is practically empty, and there are various studies which have looked at this. But clinically, it is easier to say grade 0 if the antrum is empty in supine and lateral position. There is less risk of aspiration. Grade 1, if the antrum is empty in supine but clear in lateral, it is grade 1, and again the risk is low. But if the antrum is full in supine and lateral, the risk is high. I'll quickly tell you about the lung ultrasound. The lung ultrasound, you can scan like you would do it, but there have been various, zones that have been described, but you essentially have to scan the whole lung. So the first thing that you have to know is the hyperreflective pleural line, which suggests this is the most important structure that you need to identify. It has been described as the bat wing appearance because the ribs don't cast the shadow, so it will appear black. This will give you the reflection, or the ultrasound would move into the lung and it will give you the shadows. So the only critical thing is you have to identify this movement of the pleural line. It looks like ants moving in a line fashion. This is classically called as the lung slide. If there is lung slide, it suggests that there is no pneumothorax. Okay, if you put an M mode on the pleural line, you can see something called as the seashore sign. So the skin, subcut tissue, the muscles are non-mobile, so they don't have any movement, so they will look like flat lines, but the air under the lung scatters the ultrasound, so it will appear grainy. So this is called as the seashore sign. So this is normal. If there is pneumothorax, the whole thing is immobile and it will look like a barcode sign, as contradictory to the seashore sign. It will look like a barcode sign. So this suggests that there is possibility of a pneumothorax. But confirmatory pneumothorax is only when you see for a lung point. However, the other things that you can identify are the A lines, which are like reverberation artifacts from the pleural line. So these are equidistant from the pleural line, and they are the A lines. And these rocket type or torch-like lines that start from the pleural line and end up to the end of the screen of the monitor, these are described as the pleural line. So A line is aerated lung, B line means there is interstitial fluid or alveolar fluid. So this can quantify the interstitial edema or alveolar edema, depending on the amount of lines that you see on the ultrasound. This is what I was talking about, the lung point. If you see an area where you can see the seashore sign as well as the stratosphere sign, this is confirmatory for a pneumothorax. And the last is when you put your ultrasound in the PLAPS point. PLAPS is the most dependent aspect of the lung. If you put the ultrasound, most of the pathologies are gravity dependent. So you will have pleural effusion, consolidations on these in this area. You can see and diagnose consolidation. It is also described as C profile and described in terms of signs. We call it as the shred sign. It is looking like a shredded appearance of the lung. And Daniel Lichtenstein has actually described well in 2004, long back, how to look at the lung ultrasound, whether you have no lung slide. So first thing, you look at the lung slide. If you don't have a lung slide, see whether there are A lines or B lines. If you are having B lines, you are probably looking at a possibility of a pneumonia. If you have A lines and you find a lung point, it is confirmatory for pneumothorax. If you have C profile again, or shred sign, you're probably looking at a pneumonia. If you have lung slide and B profile, you have probably pulmonary edema or alveolar edema or interstitial edema. So this is how you can use algorithmic approach to look at the lung ultrasound. And of course, transthoracic echoes, it is used for assessment of preload and volume responsiveness to look at the heart size and contractility of the chambers, and also to look at regional wall motion abnormalities. To quickly look at what are the routine images that are seen, you can look at the parasternal long axis and short axis when you keep the probe just beside the sternum with the pointer of the probe looking at the right shoulder. So this, when you look at the long axis of the heart, you say parasternal long axis. When you change the direction of the probe towards the left shoulder and cut the heart in short axis, you will see the heart in terms of circular images. The subcostal may be the most important view in anesthesia, because we may have tubes, surgical incisions. And of course, apical 4-chamber or 5-chamber is what we can look at these images. So what you see is, if you look at the parasternal long axis, you can see the right ventricular outflow tract, the left ventricle with its outflow tract along with the aorta. So, and you can also look at the size of the LA with the function of the movement of the mitral valve. At the same point, when you turn the probe, you will see a parasternal short axis view, where you will see the size of the LV and the RV, and the relationship of the LV and RV, and the relationship of the size of the LV and RV. Of course, along with and this view is good for also looking at the regional wall motion abnormalities and define the territory of the coronary event. The apical 4-chamber is when you put the probe at the apex, you see all the 4 chambers, that is the left ventricle, right ventricle, left atrium, and the right atrium, and you can also assess the function of the heart as well as the size of the chambers. And like I said, subcostal is again relationship of the right side of the heart along with the interatrial septum. And the last is the IVC variability. To assess volume responsiveness, you can look at the movement of IVC in terms of the respiration and see whether your patient is volume responsive or not. You can do it even in the transhepatic view. This is the part of VEXUS protocol. I think if we are short of time, I would probably stop here and take questions at the end of the session.
Yes, Dr. Sheel, thank you very much for that wonderful presentation on point of care ultrasound. And it was really exhaustive and very well done. Thank you. With that, I think we move on to our next speaker, Dr. Gauri Gangakhedkar. She is a very dynamic young assistant professor at our institute, and she's going to talk about perioperative serum electrolytes and point of care blood sugar monitoring. Welcome, Gauri. Thanks.
I hope my slides are visible.
Yes, they are.
Thank you. Thank you so much, for this opportunity. I'd like to thank the ICA and Jeson sir for giving me this opportunity to present on this platform. We start off with the point of care electrolytes and blood glucose monitoring. Now, to understand, while this whole CME is based on point of care management, we have to understand why point of care tests are necessary to begin with. In the clinical settings, they're required in the ICUs, emergency wards. We use them in operating rooms and even in wards and home-based testings. In the wards and home-based testing, point of care testing is basically used for blood glucose management. The advantage of these is that these devices tend to be benchtop, portable, or even handheld in nature. They help you to rapidly establish a diagnosis. Thus, they reduce the waiting time for the clinician to actually understand what is happening with the patient. And then hence they allow urgent decision-making and institution of treatment. Now, this also reduces the strain on central labs, which is what makes it possible to carry it out in remote areas or even pre-hospital rescues. So in a country like ours, to actually have point-of-care testing implemented on a large scale would be useful. There is a caveat. This comes at a cost of reduced accuracy for a lot of tests. Now let's look at point of care ultrasound to begin with. Now dyselectrolytemias have severe effects, like they affect the myocardium, the central nervous system, the musculoskeletal system, the GI tract, everything. And prompt identification and management has the potential to decrease morbidity and mortality. Now, how do we do this? If we want to decrease this morbidity and mortality, it would mean that we would need a rapid and accurate assessment, not just rapid. We would need an accurate assessment because we want to know what we're treating and what the proportion of the severity is, and thus initiate an appropriate treatment as early as possible. As a result, these can serve as a guide. These POCTs can serve as a guide in emergent situations. And in perioperative and critical care, they can serve as trend markers to see whether our instituted therapeutics are working in the direction in which we want them to. Now, what are the available electrolytes that you can get? They would be sodium, potassium, chloride, and ionized calcium. So largely, POCTs for electrolytes come from our blood gas analysis. Absolute values for these can be measured, and these electrolytes would also be useful in calculating the anion gaps. Now, what we have to take into account is no matter what you do, there is a difference in the values with the currently available technologies and the skill set that we have between the values that are calculated by ABG and those calculated in the lab. The proposed differences between these values comes from the possible addition of heparin and the difference in the sampling techniques. Now, when we look at sodium and potassium, they're the major circulating ions. So they're tested in our ABGs left, right, and center. The normal values are sodium 135 to 145 and potassium 3.7 to 5.1. They're of tremendous use in various medical emergencies. For instance, when a patient comes to us with obtunded sensorium diabetic ketoacidosis, when in a perioperative period they receive multiple transfusion or post-cardiac arrest, during the cardiac arrest, we do want to know what their electrolyte status is like. And the first electrolytes we look at are sodium and potassium. But when we look at them, is there any use to looking at these values? Hopefully this chart will guide us. So we have multiple studies that suggest that there isn't so much agreement between the lab values and the ABG values. But if you compare arterial and venous samples, there appears to be correlation, which essentially means that you needn't be pricking the patient through their arterial line, or if they don't have an arterial line, you don't need to prick their arteries. You can use a venous sample, or on the flip side, if you find that you have an artery, if you are drawing an ABG because veins are not available, you could simply run the same sample and you would have similar results. However, Ihan et al. Found that there is more disagreement between the serum potassium levels than there is at the serum sodium levels. And as far as calcium, whether the pH was acidic, alkaline, or normal, there appeared to be a difference. This difference was even more profound in children. Again, the hypothesis remains the same. It's possible that we're adding different levels of heparin. So the levels of the electrolytes seem to be lower in ABG or VBG samples as compared to central lab values. So the current evidence suggests that even if we're using electrolyte testing through ABGs or VBGs, they're better used as early screening or trend markers, but they have to be correlated with lab values and clinical status. What about the other electrolytes that we see? You have chloride, right? So in isolation, we rarely use chlorides. but we use them to calculate anion gaps. Now, where do these become useful is when we're looking at values such as hyperchloremic acidosis, where most commonly you have GI and renal causes where the bicarbs are falling and you need to know why that's happening. But it's the exogenous causes that are most important. For instance, after CPR, when you resuscitate the patient with a lot of normal saline, you're going to see hyperchloremic acidosis. You're going to see very high numbers and they need to make sense to you when you see them, hence the same. Then you come to ionized calcium. Our normal values are somewhere between 4 and 5.525. These are useful too, because here you can use them in sepsis, in hypocalcemic crises, in hypercalcemic dysrhythmia, shocks, burns, and patients who have received multiple transfusions. They're particularly useful in post-thyroidectomy patients to guide calcium therapy, and here they've been extensively studied. And we find the ionized calcium values in particular can be used as a reliable marker, particularly as a trend, if not as isolated values. So when we come down to serum magnesium, whether it is critical care or taking a critically ill patient to the ICU for surgery, we find we want to know the serum magnesium values. However, there isn't any robust data available on point of care testing for magnesium. But knowing magnesium values would be decisive in early treatment of cardiac dysrhythmias, reperfusion injuries, or significant inflammatory response. Also for intractable asthma, preeclampsia, or eclampsia. Now, how do we go about obtaining more accurate results with the current technology we have? Obviously, the answer would be to develop better technology so that these results collate with each other. But until such time that it happens, what do? We use trained manpower. So that we know what amount of heparin for what kind of a syringe. We can use pre-heparinized syringes so the amount of heparin used is uniform. We can use dried balanced heparin syringes, and we can ensure a uniformity of collection practices. The other solution possibly could be the use of correction factors. Checo et al. Found that there was no concordance in potassium values below 3 millimoles, and concordance was found above the same. For sodium, there was concordance in all values. So they suggested that a correction factor between whole blood and serum would be 4 millimoles for sodium, and for less than 3 millimoles of potassium, the correction factor 0.6 millimoles should be applied, whereas it could be 0.2 millimoles above 3. Again, it's important to have a high index of suspicion for these values. Make sure you have clinical correlation for the same, and follow up any severe dyselectrolytemic values must be followed up with lab reports to be sure. Management of dyselectrolytemia is a large topic in itself, but just to complete the topic, I have put up charts of management of dyselectrolytemia for the major electrolytes. When we move on to point of care blood glucose testing, have to understand that the most of the global, point of care blood glucose testing comprises of 53% of the global consumption of point of care testing. These originally, so point of care basically originated as home-based tests for diabetic patients, and that is what their primary use still comprises to be, even in the hospitals or in the HDUs. Serial blood sugar measurements to understand or titrate insulin therapies is what they use for. In the ICU and the perioperative period, we use the same technology to titrate the insulin or titrate the glycemic control to ensure better outcomes for patients. Now, how reliable is this? Now, in addition to looking at the reliability of point of care glucose testing kits, we also need to understand the difference in the samples, right? For instance, where for ABG you were only looking at arterial or venous sample, here you have 3 alternatives. You have the capillary testing, which is what is most commonly used for point of care. You have venous samples, and you could have arterial samples, versus your serum levels, which you sent from venous blood or arterial blood. So for that, we need to understand that physiologically, there is always going to be a 3 to 5 milligram per ml difference between arterial and venous levels. The levels are going to be higher on the arterial samples, particularly after meals. But we find that as far as point of care tests on the whole go, there is a good correlation. If you compare capillary versus arterial, Kramer et al. Found a good correlation with no clinical significance in spite of a statistically significant difference in the values of the serum blood glucose levels that they found. Yaraki et al. Compared arterial, capillary, and venous, and they found no difference, no statistical difference in the values that you get. Again, for completion on the chat, I put in a chart for management of glycemic emergencies. Now, when we are talking about blood glucose management, how can HbA1c be far behind? Now, point of care HbA1c is a test that's possibly promising to revolutionize how we look at diabetes or how we look at point of care testing or sugar management in general. It is being increasingly performed to monitor glucose control in diabetic patients. So it would help you to rapidly determine whether this diabetic patient needs to be treated. So these devices are those which would flash if the HbA1c is more than 6.5. Now, the biggest promise that these devices possibly show is that they can replace glucose tolerance tests in pregnancy. Now, Mesa et al. Did a case control study where they found that if, when they did it with point of care testing, if it was less than 4.5, you can avoid a glucose tolerance test in all patients. How does this translate to our perioperative practices? So when we look at it, when we look at HbA1c testing, we look at a patient who's coming to the OPD with diabetes. And if you are going to be just as simple as a pinprick, if you're going to be able to figure out whether the patient's glycemic control was good or has not been good for the past 3 months, you can determine how early an elective procedure can be carried out, even in the face of currently deranged sugars. And that is promising indeed. What does the Indian literature say? So in 2021, AIIMS Bhopal carried out a study where they compared venous sample, that is the central lab testing, with 2 separate devices for HbA1c. What they found was that these devices were incredibly reliable with regards to predicting poor glycemic controls. The devices were also found to be comparable to standard tests in terms of accuracy. That is the the glycemic, the HbA1c values seem to correlate very well with the lab values. And thus, these authors, that is Kadanga et al., recommend that these tests can be considered as suitable alternatives for HbA1c testing on the whole. Now, what are the applications of in the perioperative period of these? We would be able to quickly determine long-term glycemic control. For instance, when like I said before, when a patient comes to us for an emergency procedure or even for an elective one, the patient could come to us with deranged sugars. But if they had a normal HbA1c, we would be less likely to want to postpone this patient for surgery, because we would assume that these deranged sugars are an increased stress response in anticipation because of the illness or because of the underlying disease. If these deranged sugars are also accompanied by a deranged HbA1c, if it is an elective procedure, we can consider postponing the procedure. Or if it is an emergent procedure, we at least understand the risks that we are looking at, and we would ensure that tighter glycemic controls are exercised through the perioperative period in order to ensure better outcomes. Now, the limitations for this would include that there would be some amount of variability depending on the machine or the brand that is used, and there would be some amount of variability with regards to the site of testing. It would be somewhere between 0.62 to 1.3 for capillary and 1.1 to 1.69 for venous blood. So what are the future avenues for point of care testing as far as sugar or electrolytes are concerned? We would be looking at devices which have more accuracy, where there is reduced inter-machine variability or even inter-user variability with regards to electrolytes, because we're hoping that the kind of sample drawing becomes uniform. We would possibly want a more cohesive analysis, wherein with a single pinprick, I'm able to get everything, which is fairly possible right now, considering the arterial blood gas analysis gives us almost all the electrolytes and sugars we need. But I mean, obviously, it doesn't hurt to ask for more. And there would possibly be possible research on an AI-based software that allows prompts in accordance with the values provided, similar to our AEDs, which could help in remote hospitals. For instance, in remote primary care, when point of care testing was used for pre-hospital rescues, treatment in the form, here what was done was when patients had cardiac arrests, point of care testing was done for about half the patients, the other patients, nothing was done. In 82% of the patients, potassium supplements, bicarb supplements, etc. had to be started. And the survival for the patients increased far greatly if point of care testing was instituted. Similarly, there's this other study that was done in Australia where prospectively point of care testing was used for all out of hospital rescues. Here, primarily the patients either had CKD who'd missed dialysis or they'd come with chest pain for peri-MI. The treatments were started, serial POCT was done, and 126 out of 200 patients required were 126 out of the 200 patients studied were transferred to the hospital as a delay, as in their assessment was done, triage was done, and it was determined that they did not require tertiary care. They could be managed at a primary care level. On further analysis, the authors note that 48 out of these would have been transferred to a hospital as a priority had it not been for POCT. As a result, I reiterate that these AI-based softwares would indeed help at this point, because if we're going to have paramedical staff doing these rescues, it would help to have prompts which enable us to do better. In conclusion, can POCT for electrolytes or blood glucose replace conventional testing? For blood glucose, it is entirely possible, but for electrolytes, not really. We're still looking at them as trend markers or as screening tools. They definitely have a role in reducing turnaround time and the time to institute therapy. They are life-saving on occasions when you receive patients in emergencies. However, the search continues for an ideal POCT tool, which would enable closer results to what are promised by our central labs. Thank you. These are my references.
Thank you very much, Gauri, for that very insightful talk on point of care electrolyte and blood sugar testing. And that really would change the way we practice as far as relying on laboratory values and the reducing the turnaround times for getting all these results. Yes, so I think with that we move on to our next talk on thromboelastography and point of care hemoglobin monitoring. And to speak on that, we have Dr. Sohan Solanki, who is a professor in anesthesiology and a very dynamic academician. So I think we'll move on to the talk by Dr. Sohan.
Thank you, Dr. Jeson, and thank you, ICA, for this opportunity, and good evening to everybody. So my talk is on this TEG and HB monitoring. So I will be mainly speaking on this TEG and briefly about hemoglobin monitoring. So to begin with, so we all know that maintaining this blood in a liquid form or liquid state is very crucial or very critical for the homeostasis to deliver the oxygen and nutrient to the body and the tissue, and to remove the CO2 and other waste product from the body. And on the other hand, the ability of the blood to coagulate, to prevent or to protect the body from the life-threatening bleeding. And all these are determined by the complex and the active balance between the procoagulant and anticoagulant and the fibrinolysis. And we all know that some congenital disorders like some von Willebrand factor diseases or hemophilia or some anticoagulant drugs or antiplatelet agents, some major acute blood loss like during surgery or non-surgical major bleed and trauma, they all cause coagulopathy and need prompt action, and they all action needs some guide to give some blood and the blood product. And we all know that our this pathway, we are reading this from the MBBS time, that there's some extrinsic pathway, intrinsic pathway, and the common pathway. So the extrinsic pathway start from the tissue injury, and the intrinsic pathway start from the activation of factor 12 and then 11th and 8th and all this so long, and they ultimately lead to the activation of the fibrinogen to the fibrin, and ultimately into the cross-linked fibrin and the formation of the clot. So this is the coagulation pathway, and for the testing of this coagulation, we have like this prothrombin time, APTT, bleeding time, and thrombin time, and they all takes from few seconds to few minutes for the test. But they all individual tests, they do not give you a whole picture of the blood, of the coagulability of the whole blood. So for that, we need this thromboelastography or thromboelastometry, we can say, when we talk about this latter part of the talk. So this was developed by Dr. This Hartrud in 1948, and he determined the viscoelasticity during the clot formation and the overall coagulability of the whole blood by the interaction between the platelet, fibrinogen, and the clotting factors. So this is this tag machine. You can see you can run two samples at a time. There are two this cup and the pin mechanism there in every machine. You can run two samples, and you can see that there is the torsion wire. This is the cup, and this is the pin. Like this rotate into the cup, and this in this tag machine, this cup rotates around 4 and 45 every 5 seconds, and there is a 0.36 ml of the blood is needed for this coagulation. This is the this calcium chloride some blood is added in the blood, and this is the heated at the room temperature, and this cup rotates, and there is some coupling action of the this wire and the this cup. So this is heated at this 37 degrees centigrade, and the pin is suspended from the torsion wire into the blood. And I already told you this is the coupling action by the motion of the cup and the pin, and that coupling depend on the strength or the firmness of the clot. So ultimately, this electromagnetic transducers send the signals, and the signals they form to create the tag tracing. And that tracing is now then displayed in a paper or a computer screen, and the deflection of this tracing depend on the strength and the of the clot. So about the use of this tag, it is already shown in the world that it's very useful right from the at the trauma center. They use the patient is coming in the bleeding, or now it can even replace the normal routine testing. So indication of the tag is, you can say, from the trauma, the cardiac surgery. For the cardiac surgery, it cannot really replace the ACT during the cardiac bypass, but it can help after the bypass surgery or for the post-operative bleeding. And when you really want to give some blood or blood products when you're confusion, then your tag can help. In the liver transplant surgery, it's very useful. You need a baseline value also, and you need during an hepatic phase, and post hepatic phase, you will need a tag at every point of time. And you can also use during the major surgical or non-surgical bleeding, and you can also use routinely if you want to replace your routine lab testings. So the tag, this is the normal tag waveform. You can see low, so you can see have the R time and K time, angle, MA, PMA is the predicted MA, G the the elasticity of the clot, EPL is the estimated percentage lysis up to the MA. So we'll talk one by one about the each of this parameter. If you see this graph, you can see that this tag waveform can be divided into two parts. One part is the coagulation part, other part is the fibrinolysis part. So the coagulation part mainly it have the R, K, and the alpha. So R wave is mainly it's the clotting time. It depends on the clotting factor in the blood, and is the enzymatic reaction. And this fibrinogen part, which will mainly have the K and the alpha. So it will lead your clot kinetics. And your MA, which is mainly the function of the platelet. So it will tell you about the strength of the clot. And then comes the lysis part, that is your clot breakdown. So we'll tell all these parts. So I'll come first to the R times. R time is from the start from the keeping the blood into the cup to the actual starting of the this fibrin formation. So it will tell you about the enzymatic portion of the coagulation, and it depends on the coagulation factor in the blood. The normal time is around 4 to 8 minutes. So this is your R time. from this point to this point. And if this R time is prolonged, it means there is some deficiency of the clotting factor into the blood. And if this R time is shortened, then you can say the patient is hypercoagulable, or it may be during the DIC where there's a, like the initial part, there is a hypercoagulability, and then there is just some secondary fibrinolysis. The K time and alpha time, it will tell you about the clot kinetics. So K time is the like start like from the around 2 millimeter of the clot up to 20 millimeter of clot formation. It is called the K time, like from 2 millimeter here to up to 20 millimeter clot formation. This is the K time. It is mainly the function of the fibrinogen. And then comes the L angle. So it is the how fast or how rapid your fibrins are built up in a cross-linking form, and it will ultimately give the strength to the clot. So this is the speed of the your clot formation. This is alpha angle. So the alpha angle is around some 50 to 75 degree, or maybe 45 to 75 degree. So this is the alpha angle. So now I can show you like some real pictures of our hospital. Like I can say, I can see this graph. You can see that the R time is normal. You can see here it's 6 minutes, and then you see there is a K time is really prolonged. It means the patient may be having some deficiency of the fibrinogen, and your angle is also really bad. The angle is not really good, and if you can see that MA is reaching is very prolonged way. So this is this patient really can be helpful if we give some like cryoprecipitator in the post-operative perioperative whenever you are doing this tag. If you see this waveform, you can say your R time is really prolonged, and then your K and the alpha is the K and the alpha angle is very bad, and so this patient is in really bad shape of the coagulopathy. If you see this wave like wave of the tag, you can say the R time is around 85 minutes. It is very bad. Maybe patient does not have any coagulation factor into the blood, and then you can have sometimes this type of waveform. There is the like your coagulation is not even starting. We'll talk about these parameters in the later part of the talk. Then comes the MA. MA is the maximum amplitude. So it is the function of the platelets. Okay, so it will show you whether the maximum dynamic properties of the fibrin and the platelet bonding by the GP2B3A, and it represents the ultimate strength. So the clot strength is determined by the MA, the maximum amplitude. So this is the MA. So if the MA is, so it is mainly by the platelet, and some 20% is maybe because of some fibrinogen. So if the MA is decreased, it means there is some deficiency of the platelet, or maybe the platelet functions are bad. Even if the platelet count is normal, maybe the functions are not good. And if the MA is continuously decreasing, then we can say the patient is having a primary fibrinolysis. Then comes some this lysis part, this lysis 30 or lysis 60, which is actually this lysis at 30 minutes or at 60 minutes after the MA. So it will tell you about how the clot is lysis, and the normal lysis around 7.5% after the MA. Then comes some less commonly used like terms like A30 or A60 minute amplitude at 30 or 60 minutes after the MA has reached, and the EPL is the estimated percentage lysis of the clot after the MA has reached, but they are not very commonly used. So now we can say like all this about the factor like clot formation. It's the function of the clot factor. I already told you R and K time. Then kinetics is the function of this clotting factor RK, and the platelet also we tell you about the MA, and the clot strength or stability mainly determined by the MA, and the clot the breakdown is by the fibrinolysis, where you will see the lysis 30 or lysis 60 and EPL or A30 or A60. This coagulation index is also very less commonly used for this to determine the whole coagulability, but you can also calculate this CI, where you will need the R time, K time, MA, and the alpha angle, and this normal value around -3 to +3. If the patient having this -3 or less than that, you can say the patient having the problem with the coagulation factor. If it is +3 or more, then patient having a hypocoagulable state. So these are all like different type of waveform. You can see the normal, where the R, K, and MA all are normal. You can see this R is prolonged, this with some deficiency of the this clotting factor. It is MA is like slightly less. So I mean there's some platelet function. This is the fibrinolysis in this. Sorry, in this there is some hypercoagulation is there, and then you see the DIC where the two stage DIC will see. The first the hypercoagulator, and then the second stage the hypocoagulator. There's some modification are nowadays you are using for the tag. Like normally we are using the kaolin or the cellulite for the this as a reagent to measure the tag. But if you are adding the tissue factor or the TF into the this cup, then you can activate the extrinsic pathway. So in that case, you can accelerate the initial coagulation. That is called the rapid tag or R tag. And if you are using this F60 into the platelet, it can block the platelet component of the coagulation. And if you are using the platelet mapping reagent, that can really modify the allow the analysis of the anti-platelet drugs. So I told you about that like waveform, this type of waveform earlier, like there's a no start of the coagulation factor. So this type of waveform you can get if your sample has the heparin, or like it is the contaminated by heparin, or mainly into the some liver transplant patient where the after post reperfusion phase the donor liver which is mainly flushed by the heparin during the harvesting. So it will continue shedding the heparin into the circulation, and you can have this type of waveform where you will see there is a no R, then no K alpha or some MA. So for this you can use the heparinase cup. So this heparinase can reverse the heparin into the sample, and for that to see it really a contaminated sample or not, you can see that you can use the two sample like in the both chamber of the machine. So the one is the heparinase cup and one the normal cup. You can see and you can compare the two type of the waveform. If you really want to like sure if it is heparin contaminated or not. So limitation of the tag is this VHI. This is the viscoelastic hemostasis. It is routinely performed at the 37 degree. So it cannot really tell you about the hypothermia and its effect. And if the patient is on antiplatelet, I already told you, then you will need some platelet mapping agent. And it really will not tell you about the endothelial contribution to the hemostasis. And for that, you need a trained person and frequent calibration of the machine. The other form of the this thromboelastometry is the ROTEM. And so if you compare, the principle is same in the both, but if you see the ROTEM, only the pin rotates and the tag, the whole cup rotates. And the nomenclature is different into the tag and the ROTEM. Like in place of the R time, we use the clotting time into the rotate. In place of the K time, we use the clot formation time into the this. Alpha is same, and in place of the MA, it called the MC of the maximum clot firmness. And then you will see the like in place of LY30, LY60, you see this some other form of this nomenclature. But mainly the nomenclature difference is the CT, CFT, and MCF. So this is the difference between the this ROTEM and the tag. So the oscillating is the it's a 4 degree and 75, and now it's a 4 and the 45 only. And all other difference are, but the waveform and the principle are almost same, the both. Now I will very briefly tell about the hemoglobin. So where we need the hemoglobin testing. So we need during the acute blood loss, maybe the trauma or surgery or some heavy menstrual bleeding or upper GI bleeding, where you really need immediate like some value in hand to guide some whatever. And sometimes, and many times we use the intraoperatively like hemoglobin during the surgery. We all know that the conventional hemoglobin testing methods where we use, they really compare the color of the like standard and the stress sample. So the visual like the Salis method and the hemoglobin chart and WHO scale and oxyhemoglobin method, all the use the visual method, and some photoelectric methods like the sign hemoglobin, oxyhemoglobin, alkaline hemoglobin methods, all they are using for the this testing the hemoglobin. For the intraoperative point of care use, although many of these are also called this point of care hemoglobin testing, but mainly what intraoperatively we are using is like one is the most commonly used nowadays, the HemoQ. So the HemoQ is the micro cuvette the technology where the tip of this micro cuvette touches the sample of the blood at like finger, where you really need a capillary blood and not a venous blood, because this venous blood is not really good to good to use for this HemoQ. So it has some reagent and it dissolves when the blood reaches to this cuvette, and then it uses the photometric analyzer, and that it will give you some value of the hemoglobin. If you see the correlation between the the lab testing and HemoQ, so your HemoQ may give you slightly higher value of the HemoQ determined by the studies. The other study, like other monitor, which is nowadays, I don't know about much this, I just saw on the internet and I just see. It's the Bose hemoglobin monitor. It uses the artificial intelligence and this the multi-wavelength spectrophotometry, and that it uses this machine learning technology and about the hundreds or thousands of data, and then they use give you some value of the hemoglobin. Okay. So thank you very much. I really did not touch much about the hemoglobin, but I hope I covered most of the tag. Thank you.
Thank you very much, Dr. Sohan. That was a fantastic talk on thromboelastography and point of care hemoglobin testing. So thank you. And I think we are having a little bit of a time crunch. So quickly, we'll move on to the next topic, by Dr. Bindiya Salunkhe. And she's an associate professor in the Department of Anaesthesiology at Tata Memorial Hospital. And she will be talking about monitoring of depth of neuromuscular blockade. Over to you, Bindiya.
Thank you, Dr. Jeson. So today we are going to talk about the monitoring of neuromuscular blockade. So neuromuscular blockade is used very commonly while giving general anesthesia with neuromuscular blocking agents in day-to-day surgical procedures. So we require to know the initiation of this blockade when it is acted, so that for the intubation to be smooth and traumatic, and also during the recovery phase, so that there is no residual neuromuscular block. The residual neuromuscular block has been seen even after reversal of the neuromuscular blocking agent. Hello. Reversal of neuromuscular blocking agent is observed very frequently and is associated with serious complications like postoperative pulmonary complication, need of tracheal reintubation, aspiration pneumonia, airway obstruction, hypoxemia, etc. Use of clinical tests to assess recovery of neuromuscular blockade are not sensitive or specific, and detection of residual effect of neuromuscular blocking agents and may result in residual paralysis. This clinical tests are like lifting of head for more than 5 seconds, hand grip, adequate tidal volume delivery. These are the clinical tests, but they are not effective in diagnosing the residual paralysis. That's why in 2018, an international panel of experts in neuromuscular blockade made a statement which stated that objective monitoring, that is documentation of top ratio of more than or equal to 0.9, is the only method of assuring the satisfactory recovery of neuromuscular function. And if a quantitative monitor is not available, the use of peripheral nerve stimulator is mandatory when neuromuscular blocking agents are used. In 2020, the French Anesthesia Society guideline for the use of neuromuscular blocking agent recommended monitoring whenever neuromuscular blocking agents are used. In 2021, Association of Anesthetists of Great Britain and Ireland recommended the quantitative neuromuscular monitoring should be used whenever neuromuscular blocking agents are administered for anesthesia. After multiple studies and multiple guidelines, finally, the benchmark set for adequate neuromuscular recovery is an adductor pollicis stop ratio of 0.9 or greater is now required to exclude relevant residual neuromuscular block. So peripheral nerve stimulator. What is this monitor? This could be a magnetic or electronic. We are mostly using the electronic one. Monitors of neuromuscular function use stimulation of peripheral nerve and evaluate the response, that is a contraction or twitch in the innervated muscle. The peripheral nerve stimulator consists of battery-powered device that may be portable or handheld or mounted on the workstation. Stimulator wires are connected to the surface electrode placed on the skin, or the needle electrodes also can be used along the course of the peripheral nerve and optimally positioned to avoid a direct stimulation of muscle being monitored. The negative electrode is placed distally and the positive electrode proximally to ensure most effective neurotransmitter. While applying this electrode, the skin should be thoroughly clean and distance between the center of the two electrodes should be at least 3 to 6 centimeters apart. Which are the nerve muscle units which we mostly use? The most commonly used is ulnar nerve and adductor pollicis muscle, because the ulnar nerve we are stimulating here, and the muscle which is away from the stimulus is being monitored. That's why we are not going to interfere directly with the muscle stimulation. Also, posterior tibial nerve and flexor hallucis brevis muscle is a unit which is also monitored. Facial nerve and orbicularis oculi and facial nerve or corrugator superciliary muscle is one more unit which can be used. What happens when if any limb is paralyzed? In paralyzed limb, due to upregulation of acetylcholine receptor after denervation, results in resistance to non-depolarizing. Hence, the degree of systemic neuromuscular block may be underestimated in paralytic limb. That's why it should not be used, the monitoring should not be done on a paralyzed limb. What are the different patterns of stimulation? First is a single twitch. Single twitch is a stimulus involves one supramaximal stimulus every 10 seconds or every second. So this is mostly used to determine the potency of neuromuscular blocking agents and is not used clinically. So here is the stimulus which is provided every second, and here is the response. Non-depolarizing, you can also see the down regulation, similarly in depolarizing. Second is a train of four, which is most commonly used. Train of four stimulus consists of the 4 successive supramaximal stimuli delivered every 0.5 seconds, and the two top stimuli, the club of 4, should be at least 10 seconds apart. After administration of non-depolarizing neuromuscular blocking agent, responses at this frequency shows fade or progressively decreasing amplitude of responses. The top ratio is calculated by dividing amplitude of the 4th response by the amplitude of the 1st response and requires an objective measure of the response to stimulation. So here, these are the stimuli which are applied. This is the response. After administration of neuromuscular blocking agent, there is a slowly decrease in the fading of the last 2, then fading of last 3 top ratios. Here reappearance when the patient is coming off of the relaxant, and here also better count will be there. So top ratio will be calculated only at this point. Here and here, when the 4th twitch is absent, we cannot calculate the top ratio. Only top count can be calculated. So there is a correlation between the number of detected TOF counts and how much nicotinic acetylcholine receptors are blocked. So in TOF1, if TOF count is 1, it is 90 to 95% of nicotinic acetylcholine receptors are blocked. If 2, then 85 to 90%. 3, then it is 80 to 85%. 4.
Faraz?
I think, sir, due to some network issue, ma'am has got disconnected.
I will just ask her to log in
Yeah,
again and
sure.
continue from there. Yeah.
Okay, sir, I am here only.
Yeah, I think she's logged out. I've already communicated to her. She's just logging back in, and she will start from the point she's stopped, and she'll begin again.
Okay, sir, no issue, sir.
Yeah, yeah. Yeah, for us, there is some problem with her network. So she's just using her phone hotspot and logging in. There she is. She's joined
Yeah,
in
I
again.
can see she has joined.
Yeah, yeah. Yeah, Bindiya, you can share screen and continue from where you've stopped.
Yes, I'll do that.
Not audible, huh, Bindiya? I can't see your presentation yet.
So give me 2 minutes.
Yeah, yeah, sure.
Faraz,
Yes, ma'am.
can we go beyond 9 according to your thing?
We can extend
Okay,
up to 5 to 10 minutes.
okay,
10 minutes.
right. So we'll wait for Dr.
Yeah.
Bindiya.
I'm really sorry. connection.
Bindiya
I'm
ma'am, I
trying
would
to
like to
connect.
know you have joined from your laptop or mobile phone?
Yes, I had joined from the laptop prior. Now it's time to join from the mobile.
Yeah, you can share the screen from your laptop.
Laptop I had joined already, which got logged out. So now I joined from my mobile, which
Did you getting the share screen option?
I'm getting, but it's coming in the Microsoft OneDrive, which is not there in that.
Okay, that is the issue. It's difficult to share from the mobile phone.
Yes, my internet went off somewhere. Some issues came up because
Maybe Dr. Jeson, we could
Yeah, madam.
probably adjust Bindiya's lecture in some other program of all. No, Bindiya, we want to hear your lecture. It is so important.
I'm so sorry.
That's okay. You can't help it, with all these internet and all these glitches. So there's no problem at all. Farhaz?
Ma'am, if I may interrupt, sorry.
Yes, ma'am.
Bindiya has emailed her lecture to me. Can I
Yeah.
download and share screen? Maybe she can just prompt
Yeah,
me to
yeah.
switch. Would that work for us?
Yeah, Gauri.
Yeah, this will be more fine as
Just give me a minute. I will.
Yeah,
load
yeah,
that
yeah,
and I will
sure.
share.
Thanks, Gauri.
Perfect.
Thanks, Gauri.
That is perfect.
Okay, thank you so much.
I got reconnected.
Recording in progress.
Yeah. I got reconnected.
Yeah, you got reconnected, but I will request you have to leave from one device because, or you have to
I'll do that.
because your voice is getting echo. That's why.
Bindiya, you're happy to share screen or should I? I have the PPT.
Yeah, I'll share.
All right.
So I think I had stopped here. So tetanus, that is tetanic stimulation. Am I audible?
Yes.
Yeah,
yes.
Bindiya, you are audible,
Yeah,
but
yeah.
go on to slide share mode, no? I mean, the full screen mode, no?
Yes.
Yeah. Presentation mode, yeah. Perfect.
Tetanus, that is tetanic stimulation, also called tetanus, involves the repetitive stimulation of frequency of 50 to 100 Hz for 5 seconds, which causes sustained muscle contraction. Tetanic contraction fades as the level of non-depolarizing neuromuscular blocking agent induced blockade increases, and degree of fade is equivalent to the fade with the top stimulation. It is more painful and less frequently used. Post-tetanic potentiation. Post-tetanic count consists of the 5 seconds of 50 Hz stimulus followed by the series of ST stimuli delivered at 1 Hz for 20 seconds. Tetanus transiently mobilizes the presynaptic acetylcholine release into the neuromuscular junction, and therefore the response to the subsequent stimulation is potentiated. This pattern is useful during deep levels of non-depolarizing neuromuscular block with TOF count of 0. If PTC is 1, spontaneous recovery from the intermediate acting neuromuscular blocking agent to a TOF of 1 can take up to 30 minutes. Then comes the double burst stimulus, that is assessment of the 2 stimuli for instead of 4 stimuli. Might allow more accurate subjective assessment of fade, but not advantageous or TOF in objective monitoring. 2 mini tetanic bursts are delivered 0.75 seconds apart. As in the TOF ratio, the ratio is determined by the comparing the second muscle response to the first. In awake patient, it is less painful than tetanic, but more painful than a TOF. Quantitative versus qualitative monitoring. Qualitative monitoring or the subjective monitoring refers to the visual or the tactile, where we see the adductor pollicis movement and we feel it. And this is difficult to assess the trough count as well as the fade subjectively. Quantitative or objective monitor actually measures the response of the muscle to the neurostimulation. There are different types of quantitative monitors. I'm not going in detail. Most commonly is used electromyography, acceleromyography, and kinemyography. Rest all I'll just tell in brief. So choice of quantitative monitor, EMG monitor is most preferred. Advantage is it do not require unrestricted movement of the stimulated muscle and can be used when the arm is tucked at the side of the patient during surgery. Here the 3 electrodes, one at the belly of the muscle, one at the insertion of the tendon, and one in between is used. So the action potential is measured. Unlike AMG, EMG is not subjective to the reverse fade. So the baseline top ratio is not required and normalization is not required to be done. EMG monitor have a high level agreement with the mechanomyography and better agreement than AMG. And EMG monitors are better indicator of the adequate recovery of AMG as a result of greater precision and repeatability. Disadvantage being it is it can be interfered with the electrical interference in the operation room like a electrocautery and requires a manufacturer specific electroset which is more expensive. Acceleromyography. For acceleromyography, using an adductor pulses muscle, an accelerator mounted to which is made of the piezoelectric material mounted on the thumb measures the acceleration in response to the ulnar nerve stimuli. This technique is based on Newton's second law with the force equal to mass into acceleration. So mass is constant. The force is been equivalent to acceleration here. The monitor displays the trough count, and when the more than 4 twitches are present, it also displays the trough ratio. Following induction of general anesthesia, AMG device should optimally be calibrated and baseline trough ratio established prior to administration of neuromuscular blocking agent. Why? Because this establishing the baseline trough ratio is necessary for accurately interpreting the data of AMG, particularly when assessing the recovery from the neuromuscular block. The baseline trough ratio in the absence of neuromuscular blockade measured by the AMG at the adductor pollicis longa is more than 1. It can be up to 1.5. So effect of which the trough ratio exceed 1 by acceleromyography is called the reverse fade phenomena, and its mechanism not well understood. Thus, when assessing the degree of reversal, the goal should be achieving the trough ratio of more than or equal to 0.9 times the baseline rather than absolute 0.9. So if we, this is called as normalization. If we say the baseline trough ratio was 1.2 and if I require 0.9, so it should be 0.9 to 1.2, 1.0 it should be there on the monitor to say it is adequate recovery. If the monitor we consider 0.9, then it will be 0.75 in actual and it will be inadequate recovery for extubation. Then comes the kinemyography, which is again the distortion. The mechanical receptor is placed at the base of the thumb and with an index finger, and with the movement, the distortion of this electrical signals are being distorted. This sensor causes the electric signals to be generated, which are being this. Cuff pressure modality via the at the BP cuff, electrodes are integrated into the blood pressure monitoring cuff, stimulates the brachial plexus, which causes the bulk contraction of upper arm and generates the pressure, which is being calculated by the change in the blood pressure, and this is analyzed and displayed. Next is the compressomyography and phonomyography. Phonomyography measures the intrinsic low frequency sound of the muscle which happens during contraction, which has been picked up by the microphone followed by the nerve stimulation. This last 3 are under evaluation, not marketed. What is the differential muscle sensitivity? Muscle group respond differently to neuromuscular blocking agent such that the monitored twitch response may not accurately reflect a neuromuscular transmission in clinically important muscle. Example, the airway muscle and the diaphragm. So, thus, after neuromuscular blocking agent administered, neuromuscular block occurs faster in the central muscles than the periphery because of the greater blood flow to this muscle, and the drug delivery is faster through this muscle. Thus, the sequence of the recovery is first is a diaphragm, followed by the laryngeal muscle, corrugated supercilii muscle, abdominal muscle, orbicularis oculi, gynohyoid muscle, and last is the adductor pollicis. What is the clinical implication of this? So during intubation, if the deep neuromuscular blockage is confirmed by the monitoring the adductor pollicis, then the pharyngeal muscles are adequately blocked as well as the optimal intubation conditions are achieved. During surgery, the presence of twitch at the adductor pollicis is longer. The absence of this does not guarantee that the diaphragm will be paralyzed. Here, the PTC will be needed. During recovery of neuromuscular blockage, if TOF ratio is more than 0.9, then it shows the adequate recovery of the diaphragm in the airway muscle. So monitoring the facial muscle will overestimate the degree of recovery. So whenever possible, if the hands are tucked at the side, we have used the facial nerve, the facial muscle being monitored, then whenever possible, whenever arm is out, we should monitor the arm for the final result. So evaluation of recording evoked potential, there are 4 phases of block: intense block, deep block, moderate or surgical block, or recovery. So intense block, there is no response to the TOF on PTC, and reversal agent only sugammadex 16 mg per kg should be used. Deep block, no response to the TOF, but PTC, it is 1 to 3 response will be seen, up to 1 to 3, and sugammadex 4 mg per kg can be used. Moderate to surgical block, T1 to T3, first to third response will be seen in the TOF count, and the PTC will be more than 3. Sugammadex of 2 mg per kg can be used for this, and generally no cholesterol should be used for cholesterol inhibitors should be used at this point as per the Neuromuscular. Recovery, that the all return of all 4 counts are there, and TOF ratio can be estimated. At this time, the cholinesterase inhibitor should be used. To summarize, it is advisable to use a neuromuscular block monitor for all patients who receive neuromuscular blocking agent during anesthesia to guide dosing for the further neuromuscular blocking agent as well as the reversal agent. Quantitative monitoring is preferred over subjective. The ulnar nerve adductor pollicis unit is the preferred monitoring site. And antagonism with neostimulation should not be initiated before at least all 4 responses of the TOF stimulation are present. And the benchmark of adequate neuromuscular recovery is an adductor pollicis TOF ratio of 0.5 or greater. Thank you.
Thank you, Bindiya. I think barring we've exceeded the time by maybe 5-10 minutes, but I guess it is a very vast topic, and each topic, like I mentioned earlier, is a lecture in itself for maybe an hour and a half. So I would like to conclude by thanking ICA for giving us this opportunity to be a part of this academic initiative. And I thank all the speakers, Dr. Sheel, Dr. Sohan, Dr. Gauri, and Dr. Bindiya, for giving their valuable time and effort for being a part of this. What to you, Dr. Jayashree, madam?
Thank you. Faraz, are there any questions in the chat box?
No, ma'am, I've just gone and checked to the portal that there is no question from the doctors, delegates.
Right. And in case they do have, because sometimes, Dr. Jeson, what happens is that from tomorrow, it is on the YouTube. So sometimes the students, not sometimes, many students listen to it the next day. And then if there are any queries, of course, they can email us and we forward them to you. So I would like to end this webinar by thanking Dr. Jeson, doctor, and his team, Dr. Shilpushp, Dr. Gauri, Dr. Sohan, and Dr. Bindiya for the extensive talks and so going into so much of depth of each and every topic was so important, and they really went into the depth of it, clarifying and explaining the basics which are so important for the students and for all of us. So thank you very much, and hoping to see you all again on this webinar. Thanks a lot, Dr. Jeson.
Thank you. Thank you,
and
madam.
everyone. Thank you so much.
Thank you.
Thank
Thank you, madam.
Thank you, and thank you, Faraz.
Thank you,
Good night.
Faraz.
Thank you so
everyone.
much.
And
Okay.
thank you. And we are closing here, and we are very glad to have you all people on our platform, Clarnet. And it was really nice to have a session with you all.
Yeah.
And good night and take care, everyone.
And
And
we meet next week again.
yeah, and happy Diwali from
Happy
Clarnet.
Diwali to
Same
everyone.
to you. Same to you.
Bye bye.
Bye bye.